Good evening, Doctor.
I've joined.
Good evening, sir.
I'm ready anytime.
Yes, sir. We can start in under 3 minutes, Doctor. We will be live in 3 minutes.
Are we ready to go?
Yes, Doctor.
Good evening, friends. I am Dr. Narasimhan from AIG Hospital, Hyderabad. And it's indeed my pleasure and privilege to welcome you all for this digital symposium. We have 3 interesting talks, and the first one is on guideline-based therapy, which focuses on the role of ARNI. Second one is the role of SGLT2 inhibitors, and the third one on neurohormonal blockade to prevent sudden cardiac death. We have 3 eminent, interesting lectures. The first lecture is by Dr. Ashwini Mehta, who will be talking about guideline-based therapy and improving the outcome in heart failure with ARNI. As you all know, there's been a sea change in practice of heart failure, and it's indeed my pleasure and privilege to invite Dr. Ashwini Mehta to give the first talk on guidelines to practice how the outcome has improved with ARNI. Dr. Mehta, please.
A very good evening, and I'm going to today talk about guidelines to practice improving outcomes in heart failure. We all know that heart failure primarily is the abnormality of the cardiac structure or function, but what it does, it leads to failure of the heart to deliver oxygen at the rate commensurate with the requirements. And to put it in a simple words, it translates at the expense of increased filling pressures. So one of the hallmarks when you do an invasive monitoring of a patient of heart failure is the increased left ventricular filling pressures. So we have tried to categorize heart failure in various ways based on ejection fraction. If the ejection fraction is less than 40%, we call it as a HFrEF, or heart failure with reduced ejection fraction. And if it is more than 50%, we call it as heart failure with preserved ejection fraction, which is HFpEF. And in between is the mildly impaired heart failure, which is between 40 to 49%. And now, with the advent of so many new medicines, a new terminology has come, which talks about the recovery. And now there's a new term, which is known as heart failure with recovered ejection fraction also. We can also classify heart failure related to the time course. It can be a new onset, it can be transient, it can be chronic. It can be related to progression. It could be acute, stable, or worsening. Then, depending on the involvement of the heart, we even call it as a left-sided heart failure or a right-sided heart failure, and also combined heart failure. And if you look at the global epidemiology, we do not have a very good data from the developing countries. Most of the data is from the developed countries, it's from the Europe. And what you see here in this slide, that the incidence of heart failure is about 1 to 2%. Similarly, if you look at Australia, North America, and it's the same. With South America, where we have data from Brazil, it's about 1%. And in Asia, we have a different incidence which we see across the different areas, like Singapore 4.5, Malaysia 6.7, India 0.1 to 0.4, China 1.3, Japan 1, South Korea 1.53. So given the huge population of the world, it's a big problem worldwide. And if you look at the global scenario, what we know that the incidence, as I talked about, would translate into many, many patients of heart failure. And if you look at the Indian scenario, it is estimated that about 0.5 to 1.8 million new cases are diagnosed every year. But there is a problem with our patients. Most of Indian patients are younger by about 8 to 10 years. And this is based on one of the first study which was done, the Trivandrum registry findings, which told us that our patients are younger. If you look at our country, we have about 16% of the global population, 25% of coronary artery disease. And if we extrapolate, so we expect that there could be about 10 million patients of heart failure. And we know that in our country, what all data which we have, it clearly shows that HFrEF is more predominant than HFpEF, which is to the tune of 70% versus 30%. And the prevalence, if you look, is approximately 1%, and the annual mortality could be 0.1 to 0.16 million in our country. So how are Indians different? Like I already said, we present at a younger age. The male to female ratio is lopsided, 70 to 30. Rheumatic heart disease is still a big contributor. Diabetes is much more prevalent. The prognosis of heart failure is much worse. And also, it strikes at the prime time of their lives, causing much more disability. So one of the studies by the name Indus study, which was published from predominantly government institutes, it gave a glimpse into the heart failure in our country. And what it showed was that the mean age of presentation was 39 plus minus 16 years. The prevalence in the outpatient department was 22.5 below 30 years and 14.9 above 50 years, which reflects a younger population of heart failure. The estimated prevalence of heart failure is about 1%, which translates to 8 to 10 million individuals. And the estimated mortality, which I already said, is about 0.1 to 0.16 individuals per year. We have already discussed the heart failure, that how we can classify into HFrEF, mid-range or preserved, chronic or acute, class 1, class 2, class 3, and class 4, depending on the physical limitation on the basis of severity of symptoms. So what we know, it's a complex clinical syndrome, and it underlines the inability of heart to perform its circulatory function with the desired efficacy and efficiency due to structural or functional alteration. The symptoms typically are breathlessness. There could be orthopnea, PND, which is paroxysmal nocturnal dyspnea. I'd like to present here these slides directly because I think this is not carrying these right set of slides. So I think let's start here. And what we know today that in our country, the heart failure is quite different, and we have much younger people. We need to act much faster. So we know, today we can't treat patients without the RAS inhibition. And let's look at the various drugs which are available. So we clearly have drugs, ACE, ARBs, and ARNIs. And ARNIs, we know, today are class 1 indication. And it's known as PR indication because we do not have a very large number of data. But then whatever data we have is very, very compelling to use it in patients with HFrEF. Now, if you look, what are the patients, in fact, where we would not like to give ARNI and would like to give ACE or ARB? They're quite different, and like where they can cause harm. Like patients should not be administered ARNI within 36 hours and should not be given to patients who have history of angioedema. So there are various pathways which have been described now, and one of the latest which came about talked about preferring ARNI. If you look here, this clearly says that we must consider preferring ARNI whenever we are using the basic baseline drugs, whether it's MRAs, SGLT2, diuretics as and when required, and in certain class of patients, the hydralazine, and also ivabradine if the heart rate is more. But the main idea is to achieve optimal guideline-directed medical therapy within 3 to 6 months of initial diagnosis. So today, this new algorithm which has been proposed was not so new now, most of us are aware, by the AHA. Now it talks about in HFrEF clearly as a step 1, the ARNI should be preferred, class NYHA 2 to 3. And so there is a very clear move towards using ARNI much earlier and then considering the other drugs later on. So we all know that the use of these drugs occur all through the heart failure, whether it's early part, the initial admission and the initial treatment part, transition, discharge. So we know that we have number of trials in the chronic setting. It was firmly established at Paradigm that the ARNIs would reduce an increment to 20% over and above the usual drugs, and then switch over from the ACE to ARNI would lead to additional 20% reduction in the morbidity or mortality. Similarly, the evidence now has come with ADHF with the Pioneer Heart Failure study, and it showed reduction in de novo, NT-proBNP levels, and also the chronic heart failure worsening. It does show significant reduction. We also know that there is reduction, and the data reveals that during hospitalization, if you start that, there is an improvement and a further 42% reaction. What about cardiac remodeling? There is evidence to suggest, this evidence is coming from true heart failure, and how various echo parameters have shown the benefits. And the transition study reinforced that clearly that we can easily we can initiate this drug to de novo heart failure patient, and that led to a much better target dose achievement much earlier. So the idea is to start early, and we have a number of areas where which you can use. But what is stopping the use of ARNI? There are a number of worries in the minds of treating doctors, hypertension, worsening of renal functions cost, and when to start. Most of these, I think if you look at the hypertension and the worsening of renal functions, it's all comparable to ACE. Cost, definitely, it's still an issue, but then now with this coming off patent in our country, we have a number of drugs available, which is definitely cheaper than the ACE, than the original cost of the army, and almost comparable to the ACE. But remember, the hospitalization is not cheap at all. And if we consider when to start, we know clearly that the various phases of heart failure, we can clearly use it. Now, certain areas where still ARNI has been explored and is being used, like heart failure with mid-range ejection fraction. Here also in this particular class, we have various drugs, the diuretics, SGLT2 inhibitors, which have a two-way indication, and ARNI and the others, ARBs, 2B. Similarly, the MRAs and the beta blockers can be used. Now, if we look here, again, there's not a very clear-cut class 1 indication, but then in certain class of patients, you can consider, especially those patients who are at the lower end of the spectrum. Regarding HFpEF again, the indication for ARNI is class 2B, like SGLT2 inhibitors, it is two-way, like the MRAs, it's 2B again. So similarly, we still do not have that kind of robust evidence as we have for HFrEF in this particular class. The recommendations today for HFrEF management according to ACC guidelines are clear: using diuretics as needed, SGLT2 2-way, ARNI 2B, MRA and ARBs again 2B, and you can use it. And the first FDA indication opened up for the use of this in HFpEF as based on this particular guideline. I'd like to talk about low-dose capital valsartan combination, 25 milligrams. We presented this paper today, and I looked at the literature, and the purpose was to look at the use of low-dose ARNI, because many of our patients receive that, and many physicians also would like to give that. We analyzed 6 publications, 2 case reports, and we use various statistical measures. And what we found that our analysis supports that the use of very low dose, which is 25 milligram, does provide benefit. And we know that the risk of hypertension is encouraging, that it does take care, and the reduction in the anti-proBNPs and all that does happen even with a very low dose, and then subsequently you can increase the dose. However, the larger and longer follow-up is required for this. Certain issues are unresolved, like will it reduce the need for device therapy, or reduce the need for cath ablation in AF? What about the role in hypertension? These issues still remain unresolved. So if we really look here, so in the journey of heart failure patient, it came about with chronic heart failure. Then now we know that in all patients that are clinically stable HFrEF, or the early part, or even the acute decompensated, you can use ARNI. And also certain areas like HFpEF and mid-range ejection fraction, again in heart failure, the ARNIs are there which are going to be used. So just to summarize, time is essence in treatment of HFrEF. We should start off strong in HFrEF. A direct ARNI strategy definitely would be preferable. Thank you so much for your kind attention.
Thank you very much. That is a exhaustive review and finished just on time. I think are there any questions in chat box? Well, if not, I think we'll, if it's okay with you, we'll just finish all the 3 and then take up the questions. And I may have to leave in between, and you can just moderate the session. Can we have the next talk, please? Sabrina?
Yes, doctor.
Friends, I was been given the task of speaking about the role of SGLT2 inhibitors in heart failure. I would like to thank the Heart Failure Association of India for this kind invitation. Over the last 4 decades, we have seen an evolution of therapies. Early stages of heart failure, the therapy is designed to prevent further remodeling and ventricular dilatation, prevent mortality, and prevent symptoms of heart failure. And to this stepwise approach, there have been a mounting body of evidence about the use of SGLT2 inhibitors among patients with different forms of heart failure, whether it's preserved ventricular function, heart failure with reduced ejection fraction, or mid-range ejection fraction. Now, why is this universal appeal? Is because the SGLT2 inhibitors are likely to result in reduction in renin-angiotensin activation, sympathetic nerve activation, reduction of inflammation and oxidative stress, resulting in a basic mechanistic alteration of the natural history of heart failure. With or without diabetes, this seems to work very well. Several years ago, Charles Bell made this observation that heart failure is a frequent, forgotten, and often fatal complication of diabetes. As you can see, with the increasing amount of HbA1c, there is an increasing prevalence of heart failure, almost establishing a dose-response relationship between the glycosylated hemoglobin and the prevalence of heart failure. So whether it's even in normal range, with the gradation of increasing fasting blood sugar and onset of impaired fasting glucose and overt diabetes, there is an increasing prevalence of heart failure in this population. Now, why it's attractive to think of a tight glycemic control as a useful therapeutic target, several therapies which have achieved tight glycemic control have prevented microvascular complications like retinopathy or nephropathy. However, there is very little effect on the prevalence of heart failure. In fact, drugs like glitazones and gliptins actually have been shown to increase the risk of hospitalization for heart failure. And a tight glycemic control as a strategy has increased cardiovascular and all-cause mortality in the ACCORD trial. Now, why is this a problem? Because as you all know, the cardiac contraction at the level of myosin and actin and contractility is driven by generation of ATP. For generation of ATP, you need energy in the form of both oxygen and glucose coming into the myocyte, and then it generates ATP, which results in actin-myosin cross-binding and contractility. This is also useful in cardiac relaxation. Whereas when there is excess fuel, what happens is when you have excess amount of glucose being pumped inside the cardiomyocyte, but the uptake is not there, that results in increased production of reactive oxygen species, oxidative stress, and glycosylation of myocardial proteins, resulting in decreased contractility and impaired relaxation, thereby causing both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Both of them worsen with increasing glucose load within the myocyte. So whenever there is insulin resistance, you not only have higher amount of glucose coming in, and the glucose doesn't enter the pathways which it is supposed to enter, but there is a significant effect on proliferative mechanisms, especially fibrotic mechanism, whether this is interstitial fibrosis or replacement fibrosis within the myocyte. They are much higher in the presence of increased insulin, circulating amount of insulin. This is a very elegant work which was published in Circulation. Among persons with diabetes and heart failure, there is a higher prevalence of interstitial collagen, as you can see in the form of collagen volume fraction, as well as increased wall thickness in the arterioles among these patients. In addition, whenever you have severe hyperglycemia, this is the amount of capillary network in a healthy myocardium. But with significant hyperglycemia, there is rarefaction of the capillaries, resulting in functional ischemia at the level of myocytes. Even though the epicardial vessels are normal, you find there is capillary rarefaction, resulting in microvascular ischemia in diabetics. This also applies to patients with impaired glucose tolerance. So with this in background, surprisingly, even in non-diabetics, the class of drugs of SGL2 inhibitors had a profound reduction in heart failure hospitalization as well as mortality. The first trial, Emperor reduced, showed compared to placebo, empagliflozin significantly reduced the risk of heart failure hospitalization and cardiovascular death. What is important is within the first few weeks after initiating therapy, the curves seem to diverge, and the benefit is seen within a month of starting the SGL2 inhibitors in this subpopulation. This was very similar with the other class of drug, dapagliflozin, which was seen in DAPA-HF, which showed a reduction in both heart failure hospitalization and cardiovascular death compared to placebo. There was a reduction in vascular events, hospitalization among patients treated with SGL2 inhibitors. This applies to non-diabetic overall, all comers with heart failure. So across the board, whether it's young or old, men or women, black or white, you find that there is a universal benefit of SGL2 inhibitors among patients with heart failure. Across the board, whether they are on baseline MRAs, with or without diabetes, this is important, with or without diabetes, the benefit of SGL2 inhibitors are quite sustained in all these subpopulations. More importantly, within the first 12 days after initiating therapy, there is a dramatic change in terms of clinical worsening of heart failure hospitalization, and cardiovascular death. And you just need to give a drug for the first 4 weeks. You can already see there is a significant clinical benefit among patients treated with SGL2 inhibitors. So whether it's persons at risk of heart failure, especially preventing the syndrome of heart failure, this seems to be universally effective in this subset of patients. What about heart failure with preserved ejection fraction and mid-range ejection fraction? Even persons with preserved ejection fraction, you find that empagliflozin in Emperor Preserve showed a very significant reduction in heart failure hospitalization and cardiovascular death. Of course, the sample size was huge in this paper, close to 3,000 patients, both in the SGL2 arm as well as placebo arm. There was a significant benefit over the first few weeks after initiation of therapy. And the benefit of this therapy was sustained over the next 3 years. And the number needed to treat to show the clinical benefit was, if you need to treat 30 patients, you can achieve a significant benefit in terms of to show a benefit in these patients. Deliver again the same patients with heart failure with preserved ejection fraction, significant reduction in terms of composite endpoint of heart failure hospitalization and cardiovascular mortality among patients with preserved ejection fraction. So whether it is patients with EF of below 40 or persons in the mid-range ejection fraction, which is 40 to 50, or preserved ejection fraction more than 50%, you can see across the board, whenever the syndrome is that of heart failure, of congestion, edema, and dyspnea, you find there is a benefit of using SGL2 inhibitors in these patients. So this is approved by several scientific societies to reduce the cardiovascular death and hospitalization for heart failure and reduce the risk of cardiovascular death in type 2 diabetes and established cardiovascular disease. and it's used as an adjunct to lifestyle changes to improve glycemic control in type 2 diabetes, especially when you find that these patients are already at risk of developing heart failure, LVH, left atrial enlargement, slightly elevated BNP, mild effort intolerance. It's probably prudent to start them early on with the SGLT2 inhibitors. So SGLT2 inhibitors are recommended not sequentially, but along with the other drugs of ARNI, MRAs, right in the beginning for patients with heart failure. The concept of starting it stepwise is gone, and we simultaneously start SGLT2 inhibitors along with beta blockers when the patients present with heart failure. What about patients who are admitted with heart failure? Because this is a unique opportunity, because the patient's compliance as well as for this therapy is much better when it is initiated, when the patients are admitted with heart failure. So the key inclusion criteria are patients with heart failure who was admitted with acute decompensation, treated with IV diuretics, stabilized, who have telltale evidence of heart failure along with natriuretic peptide elevation and type 2 diabetes. These patients, when they were started on SGLT2 inhibitors, you find there is a very dramatic improvement in their cardiovascular mortality and worsening heart failure in these patients. So we have now enough evidence to use this drug in patients with chronic heart failure and reduced ejection fraction, chronic heart failure and preserved ejection fraction, as well as patients who are admitted with heart failure. Whereas acute heart failure with or without type 2 diabetes, then EMPLS study provided the evidence to use this particular drug in acute stable heart failure, excluding patients who are on cardiogenic shock and other causes like acute pulmonary embolism and severe renal failure have been excluded, and acute coronary syndromes are excluded. In these patients, when you start them on SGLT2 inhibitors, you find that there is a significant improvement in terms of stabilizing the patients and preventing worsening of heart failure in this subset of patients. The clinical benefit of empagliflozin was seen in patients with de novo heart failure or who had a chronic heart failure who presented with decompensation, with or without diabetes, or young and very elderly versus younger patients, men or women. All of them derived substantial benefit from the use of empagliflozin. And initiation of this SGLT2 inhibitors improved their patients' diuresis. They lost a bit of weight, and it was indirectly shown as a hemoconcentration and clinical congestion improved in these patients within the first 2 weeks after starting therapy. These trials have clearly demonstrated a significant clinical benefit, and more importantly, the safety of this drug has been established by these 2 large trials. Initiation of SGLT2 inhibitors with acute decompensated heart failure in the hospital has shown not only an improvement in heart failure endpoints, but also in terms of renal endpoints in these patients. The GFR remains preserved or even improves over a period of time in these patients. How about patients in post-myocardial infarction? Patients who are admitted with myocardial infarction after revascularization, with or without diabetes, have been randomized to empagliflozin versus placebo. The only inclusion criteria is, as a primary outcome, is to measure the N-terminal pro-BNP at the end of 26 weeks. And the secondary outcome was to look at the LV remodeling by looking at the echocardiographic parameters. This is a double-blind study which included about approximately 470 patients, 230 in the EMPA arm and 230 in placebo. And you found that at the end of 26 weeks, there is a favorable benefit of reduction of NT-proBNP, as well as LV remodeling was better among patients who received empagliflozin compared to placebo, indicating that patients with acute MI prior to discharge, if you think that they are likely to develop heart failure, large MI, it's a prudent approach to, instead of starting them on ACE inhibitors or ARB, we should right away consider adding SGLT2 therapy at the time of discharge. But we need subsequent studies to kind of reinforce these findings. So what have we learned? Number one is the traditional approach of using drugs to prevent remodeling in early stages of heart failure and then preventing symptoms from occurring. And these drugs used to be sequentially used. Now we have realized that we are wasting a lot of time in this uptitration of one drug after the other. It almost, you lose 6 months of your time. Whereas this approach of rapid sequencing of simultaneously starting beta blocker or SGLT2 inhibitors, what we find is when patients have severe decompensated heart failure, when you think beta blocker may not be the right choice, you may start with the ARB or the ARNI along with the SGLT2 inhibitor in these patients, subsequently add a beta blocker and then an MRA. This seems to be a better approach rather than sequentially adding these therapy for these patients. Now, all of us understand chronic heart failure is just not uptitrating medical therapy alone. It's a complex clinical syndrome which involves a lot of comorbidities in terms of metabolic disease, diabetes, sleep apnea, obstructive airway disease in a significant proportion of patients, cognitive impairment, and there is an interaction of a large proportion of them present with either atrial or ventricular arrhythmia, which can decompensate the heart failure. And there is an interaction of two-way interaction between chronic heart failure and reduction of GFR in these patients. So as a clinician, it's not just uptitrating one drug after the other. You need to look at the patient as a whole and tailor the therapy according to the needs of the patient. So in contrast to sequential uptitration of different therapies, we have now understood that rapid sequencing is likely to be more beneficial in patients at risk of heart failure or early stages of heart failure. Among patients with diabetes especially, we have recognized there are two large pathways. One is this impaired energetics, myocardial energetics, result in apoptosis and cell death, resulting in myocardial slippage, replacement fibrosis, ultimately resulting in enlargement of the ventricle and resulting in heart failure with reduced ejection fraction. On the other hand, when there is a triggering of inflammation and profibrotic pathways, there is a significant amount of reactive interstitial fibrosis resulting in impaired relaxation. Even this subset of patients are helped by using SGLT2 inhibitors early on in the course of therapy. So on the one end of the spectrum is myocyte loss, which result in progressive dilatation and impaired relaxation, progressive dilatation and impaired contractility. On the other hand, there is interstitial fibrosis, and apoptosis is not a predominant feature here. It's LV hypertrophy resulting in heart failure with preserved ejection fraction. At both ends of the spectrum, we feel that SGLT2 inhibitors are useful in patients with heart failure. So in conclusion, all of us realize heart failure tends to be a progressive disorder, results in significant increase in mortality and morbidity, especially late stages of heart failure is very expensive in terms of LVAD, transplant, and with their own set of problems. So it's prudent to start the guideline-directed medical therapy early on, and the sequential therapy is not the way to go. Probably you need to do a rapid sequencing of simultaneous introduction of these drugs. And we have strong evidence to suggest that SGLT2 inhibitors have a substantial clinical benefit, resulting in reduction of mortality and morbidity among patients with heart failure. Thank you very much for the patient listening. Any questions? Anything in the chat box? If not, we'll go on to the last talk by Dr. Guru Prasad. Can we have the last talk on neurohormonal blockade and prevention of sudden death, please?
Hello, everyone. I sincerely thank Heart Failure Association of India for giving me the opportunity to be a faculty, to share my views and little updates about the topic neurohormonal or neurohumoral activation in heart failure and what is the risk of sudden cardiac death or sudden cardiac arrest. So let me deal with these contents. What is this neurohumoral system? What do you mean by the neurons of the heart, hormones of the heart, and what do they do in heart failure, and what are their role and implications in heart failure, and how to manage these imbalances in the setting of heart failure. So we all know as a basic that the heart is a simple organ with 4 chambers and very decent function, systole, diastole. That's one cycle, and it pumps the blood and it receives the blood. Simple. That's the heart physiology. But the cricket lovers, I can say, it has only 2 functions. One is pumping action, that is systole, like batting, and second is receiving the blood either from the lungs or from the systemic veins, that is the catching function, diastole. Both are energy dependent active processes which require this nutrition substrates, and any one of it or both, if they have impaired, that is called heart failure. So by definition, the latest all international guidelines. So it's a syndrome complex. The end result of any damage, any insult to the heart, by the end, it damages severely, it fails. So it is the end result of multitude etiology and variety of diseases consisting of typical syndrome complex, like, but for our convenience, we can classify it as, systolic, diastolic, and forward, backward, preserved. Now we have preserved ejection fraction, reduced ejection fraction, HFAI, MRF. And the failure can be, is it myocyte failure? Is it circulatory blood related? Or the congestive, typical. It's related to speed of the pumping, that is stagnation. Eventually, it's a severe heart failure, okay? So what are the aspects of pathophysiology? Basically, I confine myself to this, the heading of neurohormonal, neurohumoral system. What are the neurons implicated? And what is the hormonal system? What is the word actually by Packard's hypothesis in 1992? They thought, people thought initially heart itself secretes, because it is somewhere, there are some neuroendocrine glands or cells that can secrete some hormones, whatever. Heart is also an endocrine organ, practically, because it secretes some of the substances. And, neurotransmitters like adrenaline, and parasympathetic nervous system, acetylcholine, it secretes natriuretic peptides, and local is, there are certain hormones which may act autocrine or paracrine way. So yes, you can consider it as an endocrine organ. So that's how the word came. So what are these neural systems in the heart? Heart is really a richly innervated organ, just like other organs, So of late, in this latest, 21st century, there's a lot of amazing modalities and investigation about neuromodulation, because heart is one tight, one really hardworking engine. It always should function. So the control, how is it? It has its own control by pacemaker and conduction system. However, the final control, like, you have state government and central government. Though heart has its own state government, the real central government is the brain and the other nervous, that is central and peripheral nervous system. Both in sympathetic and parasympathetic systems try to control the heart. How do they affect the heart? So this is one of the historical first experiment, Douglas Munn, who is one of the pioneer in heart failure in the field, is one of the editor of Brownwald also, textbooks. So you see, this was the first one, is like, it's like if you make it vertical, it looks like, Petronas or some piece per hour. So this is the one myocyte of the heart, and after few micrograms of sympathetic, drug and the sympathetic infusion, that is adrenaline was put. See, in few minutes, so the cell how it has become, and this is the full dose of adrenaline implication. See the effect of adrenaline in minutes, how it has damaged the cardiac myocyte. So that is the effect of a sympathetic hormonal effect on the heart. Now we studied more of the nervous system about the heart. This is HFAI, IVC. See the ganglionic plexi. This is the most beautiful illustrations. The heart is richly innervated by local ganglia, both sympathetic and parasympathetic. You see, it has been said that in an adult, around 800 ganglia, around 40,000 neurons, sympathetic neurons, the heart really constitutes. So which has tremendous influences on the conduction system and heart. The rating, that is a chronotropy, inotropy, dromotropy, bathnotropy. So how these balance, sympathetic and nervous, and both parasympathetic. If you see, this is a mouse model, so almost similar to human innervation. This is the, anterior wall of right, exactly HFAI, IVC zone, the parasympathetic innervating the bright fibrous structure is like SA node, just like humans, You see the interlacing of, the red one is the acetylcholine, parasympathetic nerve, and the green fiber is the node. See how intricate, how intimately the nervous system is associated with the conduction system and cardiac myocytes as well. You can see this, all the whole brain, not only spine, local, that is intrinsic cardiac nervous system, the whole, starting from cortex, everywhere, it is well regulated. And what happens in heart failure? In heart failure, when these afferent sensors, if they stop, or if they are imbalanced, they all disturb the sympathetic and parasympathetic nervous system. The sympathetic system is excessively stimulated, leading to the adrenaline, noradrenaline release, and one side and second side RAS, that is renin-angiotensin. The two pillars that are vital, balance the heart, and the energy, the circulation, the pressure, they get imbalanced, including the renal system. This is actually the parasympathetic ganglia on the pulmonary veins, and you see the ganglionic plexi, if they are stimulated, see, this is how we get atrial fibrillation. Now, this is, of course, in mouse model, same applies to human heart as well. So whenever they are abnormally stimulated, there will be triggered activity leading to arrhythmias. So that is how the sympathetic system regulates the heart, especially the adrenaline. So as I summarized, it increases the heart rate contractility and the chronotropy. Okay, so inotropy, everything. So when it is really activated beyond the compensation, so it leads to vasoconstriction, stimulation, increased hypertrophy, that's pressurized response, fibrotic response, inflammatory response, and stimulation of its core system, that is renin-angiotensin system and all. So it has the complex interaction with its brother, that is renin-angiotensin system. Both these, the two pillars especially, which are meant to compensate for a failing heart, are upregulated. They behave abnormally over a chronic period. So these are very well studied in experimental models. See, excess stimulation slowly leading to the adrenaline effect, tachycardias and atrial arrhythmias leading to fibrillation. So the initial, there is, when the heart fails, there is hyperinnervation of sympathetic nervous system, and parasympathetic comes down in a failing cardiac myocyte. So that is, it's a clear demonstration in the earlier trials also. So that beta blockade has implications in improving the heart failure. So you can understand the role of the effects of sympathetic nervous system. So even the beta blockade can improve the ejection fraction. So then coming to the hormonal, so humoral. So all of us know about renin-angiotensin aldosterone axis and its implications. Mainly angiotensin 1. Angiotensin, it acts on two receptors, AT1 and AT2. Though AT2 receptor stimulation is beneficial, But in heart failure, that is the pathological state, AT1 is more active angiotensin, that is, leading to vasoconstriction, inflammation, fibrosis, proliferation, and abnormal fibrous deposition, scar formation, remodeling of the heart. So these are the benefits of A2. But in failure, AT1 takes over, leading to all inflammatory scarring, fibrosis, and everything, leading to vasoconstriction, hypertension, and reduction of the heart rate. Increase of the heart rate. So though it is meant for inotropic effect, but eventually this fibrous process will lead to scar formation, and complex interaction of these, sympathetic and RAS system will definitely lead to eventually the failing of the heart. So the clear studies show that one of the first study, the blockade of RAS system has improved heart failure episodes and leading to reduction in mortality, morbidity. So the complex interaction between sympathetic and RAS system, that is neuro and hormonal, though it is meant for initial compensation, eventually they lead to remodeling both in the heart as well as the vessels, leading to, especially why they lead to heart failure is of course okay, but what happens during the sudden death? So heart failure, so sudden death is like an accident, and accidents, they are not spontaneous, they are induced. There is a reason for heart failure. So though of course heart failure patients can die slowly because of failure itself, they have high chance of sudden death due to arrhythmia. So especially in ischemic heart disease, though initial studies has, in real study, it was 5.5%. In the latest study, the paradigm study has shown 3.5% of sudden cardiac death, maybe because of better management. Okay. So the sudden cardiac death handling is due to, so when it comes to sudden death, usually it is arrhythmic. What causes arrhythmia in heart failure? Definitely, so all these changes, structural remodeling, especially the fibrotic, non-homogeneity, fibrous scar, and slow zones, channels, and especially if you look at this diagram, even in imaging, echocardiography, MRI, you see the scar formation, which form the diastolic potential, slow channels, like in this patient, you see the scar formation. That the chain is probably, the worst criminals dwell in narrow streets, narrow tunnels. So these slow diastolic pathways will result in VT, VF, and sudden cardiac death, just like in these patients. So of course we do ablation, we put, we implant ACD devices, and maybe there is a lot of updates in this conference about the medical therapy of this heart failure. The important, especially after the advance, concept, the proposal of 4-pillar treatment, ACE or ARB or RNA, beta blocker, mineralocorticoid receptor antagonist, SGLT2 inhibitors. All the guidelines they recommend as class 1 therapy. So neurohormonal activation, the risk of sudden cardiac death. So definitely both are related. The cause of sudden cardiac death is usually arrhythmic and VT-VF, though there are medications in interventions and the drug therapy, especially the 4-pillar trials, and anyone, even starting from ACE, the landmark trials, most of these ACE, ARBs have shown the tremendous improvement. It is a multitudinal approach prevention. And a word about neuromodulation, because sympathetic nervous system, RAS, has tremendous contributions of this remodeling and sudden cardiac death. There are some trials, especially rhythm trials. So these are especially to show that the reduction of the sympathetic flow, especially this is to show that sympathetic nervous system reduction, input reduction, and parasympathetic upregulation can produce. So in experimental models, once the ischemia is induced by LAD occlusion, when you start stimulating the parasympathetic system, the ischemic burden, arrhythmic burden is less, especially in a canine model. You can see after ablation of ganglionic plexi, the heart rate has declined. And this is one important study, just to show that the important trial, the the basis of Anthem HF trial. When you start stimulating the vagus nerves, you can see diastolic pressures have improved, volumes have improved. So improving the outcomes. This is one positive study, trial-based Anthem HF trial. We have another Nectar HF, Innovate HF trial. So this is just to show sympathetic vesicles have come down after vagal nerve stimulation, to show that sympathetic reduction of sympathetic inputs will improvise the cardiac outcomes, especially in heart failure patients. This is a dog model, stimulation of these vagal systems, adjusting the heart rate. Of course, it has a paradox, that is a U-curve. At one point, that may produce adverse effects, but if you have ideal controlled situations, if you stimulate the parasympathetic systems. So latest trials, this is the good summary that, especially Anthem HF trial, we have reasonable evidence that heart failure test, especially ejection fraction, 6-minute walk test, and Minnesota quality care, everything has improved. So apart from drug therapy, device therapy, ablations, so neuromodulation has giving us promising results in the latest trials. Maybe we hope in future, definitely the upcoming trials and the more novel innovations in treating heart failure will throw us definitely some light in improvising the patient quality and care. Thank you very much.
Good evening to you all. I am Dr. Sanjay Mittal, and I am going to discuss with you the importance of heart rate modulation in heart failure. The whys, the whens, and how. Quickly, what is important today is when we have a failing heart, there is some of the ways we have to manage the strain on the heart and let the heart recover. I start with this case. A young gentleman, Mr. JB, who was a medical intern, presented to us with progressively dyspnea on exertion for the last 2 months, and it started after a febrile illness. He was admitted in ICU with LVF and YJ class 4 and orthopnea. Pressures were okay, 130 by 80 at that point in time, but pulse rate was very high, 122. Respiratory rate was tachypnea, JVP and p-bilirubin was there. Creatinine was okay at that point in time, but NT-proBNP, as was expected, was in 5,200 something. ECG just showed sinus tachycardia with T-wave inversion. And this, you would agree with me, is a very common situation which comes in life. Ejection fraction was just 15 to 20%, and there was significant degree of mitral regurgitation as well. The GLS did show very poor ventricular contraction, and the high end diastolic pressures were there. What we did was, as the person was in heart failure, the first thing was NTG drip and Lasix, which was started at 5 milligrams per hour. It did improve dramatically within a day, decongesting and settled down, but the blood pressure had dropped down to 90 by 68 millimeters of mercury, and heart rate was still 106. Saturations are okay, and what we did at this point in time to reduce the heart rate, we started ivabradine 2.5 milligrams twice a day and added spironolactone to the furosemide drip, and we could taper off the nitroglycerin drip because the blood pressure was low, and that's why he was not tolerated. On day 3, his blood pressure was still 95, pulse rate had dropped down to 90 beats per minute, and at that point in time, we could elevate ivabradine to 5 milligrams per twice a day. Perindopril was added 2 milligrams, and a Lasix drip was stopped and boluses was started. And the person did continue to improve, and on discharge, which was about a week after his admission, He was still in Weiche class 3. The ejection fraction had improved to 20 to 25. Evaporating full dose, small dose of bisoprolol was added at this point in time. And this person was registered for heart transplant at this point in time. Outdoor, this person was followed up after a week. His pressures were a little better. The beta blocker could be increased at this point in time. And we did continuously follow it up for a few months and few weeks. And the outcome at 4 weeks was, 2 months was that his beta blockers were maximized to about 10 milligrams of bisoprolol. Evaporatin was then down escalated and continued in perindividual spironolactone. The best thing was, after a year of this, his ejection fraction has actually normalized 55%, and he was off the transplant list with a very good VO2 max. What this case brings to our attention is the role of heart rate modulation. Why do we need it? So the data is very clear, and this is the data from 2010, that every 5 beats increase in heart rate increases the risk of development of heart failure by 16%, even people who do not have a heart dysfunction at this point in time. And this data very clearly over the period of 24 months shows people who have more than 75 beats per minute have maximum chances of heart failure as compared to those who had less than 60 beats per minute. On the other side, if people who have heart failure and have been discharged from the hospital with an elevated heart rate, they have a much higher risk of 1 month rehospitalization within a month. And this is as high as 26% higher risk of events. And this is significant as the p-value is concerned. And this is people who were discharged with heart failure. So this is a U-shaped curve. If we look at the best outcomes is 61 to 70 beats per minute, but as we go lower or as we go higher, the risk of hospitalization within a month is much more. What to talk about hospitalization, even 1 year mortality is also directly linked to heart rates. Less than 64 beats per minute is the best, and more than 80 beats per minute is the maximum mortality with the minimum survival. So this green curve has the minimum survival, and the p-value is highly significant. Almost 41% reduction in survival or increase in mortality is noticed if we increase the heart rate by as much as 15%. So that is something which is important to be noted. The best survival is when the heart rate is between 58 to 64 beats per minute. Let's talk about medications. This is very clear now that if we look at beta blockers, which are the gold standard to reduce the mortality and also the heart rates, it is very clear that the effect of beta blockers is maximum if the heart rate reduction is also maximum. So it is directly proportional. So if the heart rate drops by 15 beats per minute, the risk reduction of mortality by beta blocker is 36%. However, if the heart rate reduction is 8 beats per minute, the risk reduction is just 9%. So the higher the rate reduction by beta blockers, the better the outcome. So that is the result of the meta-analysis of 23 trials amounting for 19,000 more patients on beta blocker therapies. Unfortunately, in India, the scenario is much worse. If you look at in India, more than 70 beats per minute, 80% of people with stable CAD are having heart rate of above 80 beats, 70 beats per minute. And only 2.5% of patients in India have heart rate less than 60 beats per minute. That is as compared to rest of the world, which is much better. And heart rate, as far as heart failure is concerned in India, the rate is less than 70 beats per minute, which is target. And in India, unfortunately, the average rate in heart failure discharge people is 96 beats per minute, and that is dismal. And that is why the risk of outcomes in hospital mortality and recurrence of hospitalization is much more. The second question which I want to bring out to the notice is, if the heart rate is high, beta blockers are the gold standard, but there are problems with the beta blockers. Well, without doubt, best mortality reduction, earliest mortality reduction is with beta blockers. Specifically, if you look at the sudden cardiac death, whether it was Merit-HF, whether it was Cibiscu, or whether it was carvedilol carbonicus trial, it was maximum sudden death reduction, which is earlier on by beta blocker addition. But the problem with the beta blocker is they reduce the heart rate and reduce the mortality. But what happens is the reaching of target dose is very difficult and takes months for us to reach that target heart rate. And reduction in exercise capacity, unfortunately, happens during the initial phase because of the precipitation of heart failure, which is very cautiously to be observed. And unfortunately, hypotension and respiratory distress is also very common. To the tune of the fact that in Asian heart failure registry, what to talk about the global picture? If you look at the target dose of beta blockers in the major trials of the beta blocker, the carvedilol trials or metoprolol trials, most of the problem is that the beta blockers, whether it is metoprolol succinate, carvedilol, or bisoprolol, majority of them are on 50% of doses. And you can see that. And this is what is the biggest dismal. And we're talking about the best legitimized clinical trials globally. And if you look at the real world scenario, this is much worse off. The second problem is if we build up the dose of beta blockers, in the best of the scenarios, in 400 days, the maximum proportion which reached to the target dose was just 40%. In the common sense people who were being treated on home or by regular care, it is much dismal. So that is something which is the real world scenario. And that is something which brings to us a point, what can be the other options? The other option is ivabradine, because ivabradine is a funny channel blocker which leads to a slowing down of the slope of the depolarization, spontaneous depolarization sinus channels, which leads to a reduction in the heart rate without reducing the blood pressure or reducing the cardiac output. So if you look at what happens after the ivabradine input is the cardiac output status quo, nothing changes. The left ventricular systolic work increases by 53%. Stroke volume also increases by 51% because of reduction in heart rate and increase in the diastolic filling. The importance of heart rate reduction again with ivabradine is that it is the basal heart rate dependent. That means higher the basal heart rate, more is the reduction in the heart rate. If the basal heart rate was just 60 to 64, the average reduction is just by 5 beats per minute. If it was more than 85, the reduction is more than 23. So it is basal heart rate dependent. The more the heart rate, the better the results of ivabradine. Another point which I want to mention here, what is the evidence? Does it do any benefit? SHIFT trial was a big trial in heart failure which showed people who had a heart rate more than 70 beats per minute had a whooping 18% relative risk reduction of repeated hospitalization of overall mortality. Although the mortality overall was not as substantially reduced as compared to the repeated hospitalizations. But if you look at the subgroup analyses, it showed that it was not the first hospitalization, but repeated hospitalizations, the second and third hospitalization, which was all significantly reduced. The other important thing is if the heart rate was higher in this particular group, more than 75 beats per minute, we did see the mortality benefit as well. Death from heart failure, all-cause mortality, all were substantially towards the left of the midline, which means favoring ivabradine. And that is something which is important to understand. The higher the heart rate, more is the need for using ivabradine if the person is not tolerating or not proper dose of beta blockers. Another thing, this is a real world scenario. Again, a small study, 69 patients only. Addition of ivabradine on top of carvedilol showed much better 6-minute hall walk test in 5 months, much better ejection fraction at 5 months, and much better NYHA class at 5 months. So over and above beta blockers, ivabradine is much better for the outcomes benefit. The last point which I want to mention here is that how early we should add. So we do remember when a person has been admitted with heart failure, the 3 months outcome is dismal, 30% death in 3 months. And also 50% of them would not survive 5 years. That's a whooping mortality and morbidity. And adding beta blocker ivermectin earlier on, within a month, it shows the graph parting and significant p-values for the outcomes of recurrent hospitalization benefit, even in SWIFT trial. So 1,186% patients who were previously hospitalized and discharged, they showed addition of ivermectin was much beneficial. Another thing is this is the 1 year mortality benefit in this particular study, which I'm quoting here. There was huge benefit in people who have heart failure with reduced ejection fraction by addition of ivermectin. And this is the real world scenario, which means in the real world scenario, addition of ivermectin earlier on shows that the mortality benefit at an end of the year is whooping 52% reduced as compared to those who were not subjected to ivermectin. And last but not the least, that today we have enough data. If we add discharge, add ivermectin on top of the conventional treatment along with ARNIs, there's 36% risk reduction as compared to those who were not added any of them. And this is again the slide which shows the all-cause mortality as well as cardio. In people group who are in live real-world scenarios, there's a benefit with addition of beta blockers, ivermectin earlier on over top of beta blockers. And this is the reason why the guidelines have changed substantially. You look at the European guidelines from 2016, it did say one, then top of the other, then third, and it took many months for the addition of ivermectin. But today it's very clear. You add all 4 pillars as early as possible, probably before discharge. And if the heart rate is still high, consider ivermectin to be added. And this is what is important message which we need to transfer. So ladies and gentlemen, the take-home message of my talk are that most Indian patients with heart failure have a high rate, heart rate, more than 70 beats per minute, leading to a higher risk of CV mortality and rehospitalization even after discharge. Controlling heart rate with ivermectin significantly reduces mortality and hospitalization while improving quality of life and health status of heart failure patients. Several real-world evidence is available now to benefit of early addition of ivermectin at discharge, just like the case I showed you in our presentation to begin with. And this is the reason why European guidelines have classically changed the concept of adding ivermectin earlier on. Early escalation of therapy with ivermectin is accepted in the guidelines in 2021 European Society of Cardiology. And nowadays that we have once a day ivermectin dose, even the compliance is better. So thank you for your patient listening. We are ready for questions. Thank you.
Evening, everybody. I'm Dr. Aditi Dattagupta. I'm Assistant Professor in Cardiology in St. John's Medical College and Hospital in Bangalore. So the topic assigned to me for discussion is heart rate, a prognostic factor and therapeutic target in chronic heart failure, and the distinct role of drugs with heart rate lowering properties. So just a brief description of what I intend to cover in this presentation. So firstly, whether heart rate is a modifiable risk factor, the epidemiological data to support it, the pathophysiology of how increased heart rate causes increased adverse cardiovascular events, trials to support, implicate heart rate as a risk factor, drugs which lower heart rate, the target in heart failure, heart rate target, and conclusion. So to begin with, heart rate has been proven as a modifiable risk factor in cardiovascular disease and heart failure. So there is majority of epidemiological data which implicates that high heart rate leads to high CV mortality and also adverse events. Also, increased heart rate leads to progression of atherosclerosis, increased incidence of plaque rupture. A long-term follow-up study in Framingham series shows that mortality increases by as much as 14% for every 10 beats elevation per minute of heart rate. Also in heart failure, a resting heart rate more than 80 beats per minute leads to myocardial dysfunction, deterioration of heart failure. In the SHIFT study, which involved studying ivabradine and its heart rate lowering effects in heart failure patients with reduced ejection fraction, heart rate more than 70 beats per minute is associated with increased risk of hospitalization, and heart rate more than 75 beats per minute leads to increased risk of cardiovascular death. So coming to the pathophysiology, the mechanism by which higher heart rates drive the prognosis is less clear, and there are more than one mechanisms. The common ones are like increased heart rate obviously increases the myocardial workload. There is increased myocardial oxygen consumption. Increased heart rate leads to shortening of diastole and so decreased myocardial perfusion. Also, with increase in heart rate, the shear stress increases, which triggers inflammatory endothelial cell response. High resting heart rate in humans have been proven to be associated with inflammatory markers for endothelial dysfunction and also related to carotid and aortic stiffness. So these are all harbinger of atherosclerosis and other cardiovascular diseases. This is a cartoon just to drive the same points that the increased heart rate has bad prognosis in not just chronic heart failure, but other factors also like progression of atherosclerosis, increased ischemia, adverse remodeling. It also has been shown to increase certain comorbidities. So definitely it is a target wherein if we reduce the heart rate, it should give beneficial effects. So what is the evidence that heart rate is a risk factor? It is an association definite, but to implicate it as a risk factor, reducing heart rate should show improved outcomes. So there is beautiful trend which studies ivabradine in stable coronary artery disease and left ventricular systolic dysfunction. Here, patients with resting heart rate of more than 70 beats per minute had an increased risk of cardiovascular mortality and also vascular events. However, in this trial, cardiovascular death and events were not significantly reduced by ivabradine. There is REACH registry, which also showed association of heart rate reduction in patients with better outcomes. On target study, the secondary analysis showed that high heart rate was connected with an increased risk of stroke and heart failure hospitalizations as well as cardiovascular death. There are several established beta blocker trials like CIBIS for bisoprolol, MERIT HF45 for metoprolol, Copernicus for carvedilol. They have been there, and that is the reason beta blockers are now strongly recommended in heart failure. So they have also shown a significant association and heart rate as a risk factor. So prolonged survival, reduced hospitalization for worsening heart failure has been observed if the heart rate is reduced. Also, in the SHIFT study, which is ivabradine study in systolic heart failure, the goal of this study trial was to evaluate the heart rate reducing agent ivabradine compared with placebo in chronic heart failure. And it showed definite benefits with regards to cardiovascular incidence of cardiovascular death, hospitalization due to heart failure, and also worsening heart failure. So now when coming to the association of heart rate in heart failure with preserved ejection fraction, there is less evidence compared to the reduced ejection fraction. But there is a post-hoc analysis from iPreserve trial, which is irbesartan in patients with heart failure with preserved ejection fraction. wherein patients who were above 60 years of age with EF of more than 45% in sinus rhythm, in them, heart rate was found to be an independent predictor of adverse clinical outcomes. However, in patients with AF, there was no relationship of heart rate and outcomes. In a post-hoc analysis of chart 2 study, increased heart rate at baseline and in sinus rhythm patients with EF more than 50% did increase all-cause mortality and also cardiovascular mortality. So coming to the drugs which reduce heart rate, this table just briefly depicts the mechanism of action and indication. These drugs have been around for quite some time and have strong recommendations, especially beta blockers and ivabradine. So most of it, if you see, are recommended in heart failure with reduced ejection fraction in sinus rhythm as well as AF. Ivabradine can only be given in heart failure with reduced ejection fraction in sinus rhythm. I would be, presenting each of the drugs separately and, few salient points. So coming to ivabradine. So the sinoatrial myocytes are characterized by the presence of a slow spontaneous depolarization current during the diastole. This ivabradine inhibits this one sodium potassium ion channel, which is a hyperpolarization activated cyclic nucleotide gated channel. What it does is it prevents the sodium influx and hence it delays the depolarization. So it is HCN is a non-selective cation channel and it generates the F current, also named as the funny current. So it modulates the slope of the spontaneous depolarization in the sinoatrial cells. And this slope is what determines the resting heart rate in heart failure patients. This is again a picture to depict the same thing, that when the channel is open, ivabradine binds to this channel and prevents the influx of sodium. So this slope is slowed down and that's why the heart rate is reduced and hence the beneficial effects. Now, what is the evidence to use ivabradine? So in the SHIFT study, that is the systolic heart failure treatment with IF inhibitor ivabradine trial, which studied the effect of heart rate reduction by ivabradine in addition to guideline-directed medical therapy on CV outcomes and quality of life of patients in heart failure with reduced ejection fraction. It significantly reduced the heart rate compared to placebo by an average of 10.9 beats per minute at 28 days, 9.1 beats per minute at 1 year, and 8.1 beats per minute at the end of the study. So it was associated with a lower incidence of CV death or hospital admission for worsening heart failure compared with placebo. This is again the results from the SHIFT trial, and you can see that the p-values are so significant when coming to the primary endpoint of CV death or hospitalization admission for heart failure, and also the composite of CV death, hospitalization for worsening heart failure, or non-fatal MI. So ivabradine did show beneficial effect. In the subgroup analysis of the SHIFT trial, in patients with baseline heart rate more than 75 beats per minute, all the primary endpoint, all cause death, CV death, hospitalization, the data favored ivabradine. So what is the formal recommendation for ivabradine? The ESC 2021 heart failure guidelines gives ivabradine a class 2A-B recommendation in patients with low ejection fraction, that is EF less than 35%, who are in sinus rhythm. This is important because ivabradine cannot be used in atrial fibrillation. It acts only on the sinoatrial nodes. And a resting heart rate more than 70 beats per minute, in whom despite of treatment with evidence-based dose of beta blocker and maximum tolerated dose and ACE inhibitor or ARNI, MRA, you want to achieve a lower heart rate, you can add ivabradine. Also, ivabradine can be an add-on in patients with the low ejection fraction in sinus rhythm who have a resting heart rate of 70 beats per minute but are unable to tolerate any further increase in beta blocker. So in these two patients, ivabradine has a recommendation. Beta blockers have been proven to be beneficial. Now their mechanism of action, as we all know, sympathetic nervous system activation accelerates LV remodeling, worsens myocardial function. So what beta blockers do is they reduce the harmful effects of the excessive and continuously increased adrenergic drive on the myocardium. And they cause time-dependent improvements in ventricular structure and function. They improve contractility in hibernating myocardium, that is myocardium which is viable but it's not contracting. Even in them, beta blocker is shown to increase contractility, and also in non-ischemic etiology. So the beneficial effects of chronic beta blockade in heart failure occur despite an initial and transient decrease in contractility. So it has a benefit in chronic heart failure. So the evidence, beta blockers have a lot of evidence. There are proven studies. Here, this is a chart just to list down a few. The US carvedilol study, CIBIS-2, MERIT-HF, and Copernicus, they all have shown statistically significant benefit in heart failure patients. So coming to recommendation, beta blocker with all those strong evidence to back it is a class 1A recommendation to reduce the risk of heart failure hospitalization and death in patients with heart failure with reduced ejection fraction. Now, the other drugs which I would like to talk about is digoxin. Digoxin has been around for a long time. Its mechanism of action is it inhibits the membrane sodium potassium ATPase channel, which promotes the sodium calcium exchange. So the increase in intracellular calcium concentration, it mediates the positive inotropic effect which digoxin gives. It is also known to reduce heart rate by stimulating the central vagal nucleus and enhancing cardiac vagal tone. Also, digoxin may reduce heart rate by reducing sympathetic nervous system activity. It slows conduction of both sinoatrial and atrioventricular node cells. So just like beta blockers, this also acts on both. Digoxin can reduce the ventricular rate in both sinus rhythm and AF, unlike ivabradine, where it is only sinus rhythm. What is the evidence for digoxin? The DIGE trial, that is the Digitalis Investigation Group, in that trial, it was seen that fewer patients were hospitalized for worsening heart failure in the digoxin group compared to the placebo group with a significant p-value. Also, the combined outcome of death due to worsening heart failure or hospitalization related to heart failure was lower in the digoxin group. But digoxin overall did not reduce the mortality. It reduced the rate of hospitalization and worsening heart failure. So it may not have a overall mortality benefit, but it is still used as in specific cases of heart failure, especially chronic heart failure, as it reduces the rate of hospitalization and worsening heart failure. So what is the recommendation in patients with heart failure with reduced ejection fraction in whom heart rate is not controlled with beta blocker therapy? Digoxin may be added. It is also used as an alternative to patients intolerant to beta blockers. In heart failure with reduced ejection fraction and atrial fibrillation, it is the second line drug to control ventricular rate. Once when beta blocker also doesn't control, then you can add digoxin, as ivabradine is not an option in AF. In combination with beta blocker, the combination of beta blocker and digoxin has been found to be superior to any one drug alone to improve the symptoms of LV dysfunction and to control ventricular rate. Also, in heart failure with preserved ejection fraction and atrial fibrillation, it is the preferred second choice of drug to control heart rate in combination with other drugs like a beta blocker or a CCB. So the recommendation for digoxin as per the ESC 2021 heart failure guidelines is it has been given a class 2B recommendation. So it may be considered in patients with heart failure with reduced ejection fraction who are symptomatic in sinus rhythm despite treatment with an ACE inhibitor or ARNI, a beta blocker, and a mineralocorticoid receptor antagonist. So to reduce the risk of hospitalization, it can be added as a 2BB recommendation. Now coming to the drugs verapamil and amiodarone, they are not used frequently. They are used in case-to-case basis. Verapamil, coming to the mechanism of action, it's a non-dihydropyridine calcium channel blocker and it blocks voltage-gated calcium channels. By blocking these calcium channels during the plateau phase of action potential, it causes negative chronotropic effect, which slows the sinus rate. And additional negative dromotropic effect at the AV node is also there. On this basis, they could be recommended to control heart rate in patients with AF or with flutter. But as I said, it is case-to-case basis, and first, the initial first-line drugs are used. Coming to amiodarone, it works with more than one mechanism. It blocks the potassium channels, thereby prolonging repolarization. It also has anti-adrenergic effects and prolongs ventricular and atrial refractoriness. It suppresses supraventricular and ventricular arrhythmias with a relatively low incidence of proarrhythmia. It is the only antiarrhythmic drug which is recommended in heart failure. So coming to the evidence or recommendation of giving a CCB or amiodarone in chronic heart failure, it doesn't have a routine recommendation. It is generally avoided in patients because it shows no functional or mortality benefit. Like I said, in case-to-case basis in atrial fibrillation, they are added for rate control. There are two trials which have been there for diltiazem in heart failure, but the results have been conflicting. The DD trial and the multi-center diltiazem post-infarction trial. So what is the target in chronic heart failure for reducing heart rate? Because it is a proven modifiable risk factor. So based on the SHIFT data, SHIFT trial, the ivabradine trial data, outpatients with chronic heart failure with reduced ejection fraction and sinus rhythm, a heart rate of 55 to 60 beats per minute can be recommended as a target heart rate value. Also, other observational analysis have recommended that a heart rate of 55 to 65 beats per minute gives the lowest event rate. This is with beta blocker therapy also. So whichever heart rate lowering agent you're using, the target is around 55 to 65. Once a target of 55 beats per minute is reached, it is accepted as a lower limit for safety purposes. In cases with atrial fibrillation, the optimal ventricular rate in heart failure with preserved ejection fraction is uncertain in both sinus and in AF. So in HFpEF, there is no proven target. And reducing heart rate too much in patients with preserved ejection fraction could be deleterious, as it may cause a rise in atrial pressures and worsen the congestion. So coming to conclusions, there is a substantial body of evidence that heart rate is a potential therapeutic agent. It is a risk factor in patients with chronic heart failure and LV systolic dysfunction who are in sinus rhythm. As we have seen in the previous slides, beta blockers remain the first line therapy to reduce heart rate, and they have shown to improve clinical outcomes in patients with heart failure with reduced ejection fraction. In patients with heart rate with reduced ejection fractions or with CAD and LV systolic dysfunction in sinus rhythm, whom the heart rate persists to be more than 70 or 75 despite beta blockers. As we have seen previously, there is data from trials that the more than 70 increases adverse outcomes. In fact, more than 75 mortality outcomes are worse. So first we titrate the beta blockers to the maximum tolerated dose. And then if still the heart rate remains high, ivabradine is added as an additional add-on therapy, and it is shown to improve clinical outcomes. The other classes of pharmacological agents to modulate heart rate in chronic heart failure, the choice depends on heart rhythm, whether patient is in sinus rhythm, in AF, whether the ventricular rate is not controlled with the other drugs, the comorbidities and the disease phenotype. Also, digoxin is primarily used for ventricular rate control and is always combined with beta blocker in patients with reduced heart rate, heart failure with reduced ejection fraction and atrial fibrillation. But the optimal ventricular rate has yet to be established. In low doses, digoxin is an option for symptomatic heart failure with reduced ejection fraction in patients with sinus rhythm, only if they are intolerant to beta blockers. So beta blockers do remain the first line. Amiodarone is an alternative to digoxin in patients with heart failure with reduced ejection fraction and atrial fibrillation. And verapamil may be beneficial in patients with preserved ejection fraction and heart failure, but the data or evidence to support it is sparse. So thank you. I would like to conclude my presentation here, and then we'll be open to any questions from audience. Thank you.
So, good evening, everyone. I know this is the last session of today, and I won't take much of your time. Just a novel concept which we can act on in the future to help in better caring for our patients. That's what I'm going to discuss. So, heart rate, as we know, is a critical interventional concept in heart failure and cardiac diseases. But what if the heart rate is a marker in other diseases such as cancer or other chronic diseases? And if controlling the heart rate improves the lifespan or the quality of life of these patients, that would be of tremendous help. And that's what we are going to talk and address today for a short while. So please bear with me. So yeah, heart rate, why heart rate is so important? Because it is so easily detectable and measured. It can be measured just by palpating the pulse, or by a device like a finger pulse oximeter, or even the smart devices such as Apple Watch or any other device which has a heart rate sensor. So it is an indicator of cardiac adaptation to metabolic needs in health and in disease. So in systolic and diastolic heart failure, heart rate reduction has already been proven to have a reduction in heart failure hospitalization in this subset of patients. So in individuals whose heart rate is above 75, if we are able to get it down to less than 75 with rate control agents like secondary drugs like ivabradine, after added to a beta blocker, which is a first line drug, has shown significant benefit in reduction of heart failure admissions and all-cause mortality, and in the entirety, the quality of life of the patient and our answerability to the patients. So heart rate reduction in other diseases is not a new concept, but how significant it is and how are we going to achieve that, and is it going to show any benefit by intervening it actively, is what we are looking at today. So heart rate in chronic heart failure is sensitive to treatment, and now it qualifies as a modifiable risk factor rather than just a risk marker. So reducing heart rate is also associated with improvement of endothelial function and vascular function, which is one of the key concepts why we are behind heart rate reduction in heart failure patients. So other non-cardiac conditions which are associated with microvascular disease might also be dependent on the heart rate. This entire talk comes from this school of thought. So in diseases such as COPD, pulmonary hypertension, diabetes, and multi-organ dysfunction, heart rate is independently related to mortality. There is a correlation between high heart rate and mortality. So in high-risk patients, high heart rate is also associated with new onset microalbuminuria and macroalbuminuria and end-stage renal disease. So high heart rate is also associated with cognitive decline and neurological deficit after second stroke in some studies. And it is also associated independently with erectile dysfunction. So what is the hypothesis that we are trying to propose today and trying to act on today? In patients with colorectal, pancreatic, and non-small cell lung cancer, high heart rate was associated with higher mortality. So the threshold of heart rate of 75, more than 75, independently predicted mortality after correction of the covariates. So the hypothesis of Anchor et al., which this entire paper or this discussion is based on, addresses the concept of supportive care by heart rate reduction in cancer patients. So an interventional study with specific heart rate lowering drugs such as ivabradine will show in cancer heart rate is only a risk marker or a modifiable risk factor for death. Just like in heart failure, the concept of association and then intervention with heart rate lowering drugs has shown benefit. Will it show similar benefit in patients who are having carcinoma and high heart rate? Is the topic of discussion and topic of keen interest. So this relation, whatever we are talking about, high risk and high heart rate, is associated only when the patient is in sinus rhythm and not in atrial fibrillation. There are no studies, and future studies are needed in atrial fibrillation also to establish this fact. So heart rate reduction in various diseases, heart failure, it has shown significant benefit, intervention, and by medications reducing the heart rate further has shown beneficial in heart failure. And in coronary artery disease, not much benefit. In multi-organ dysfunction syndrome, what happens, we have to see. And in pulmonary diseases, renal disease, stroke, and cancer, how it goes. Does reducing heart rate reduce the mortality too and improve the quality of life is what we are looking at and what we should look at in future. So in heart failure, heart rate reduce the endpoints, whereas in stable coronary artery disease, acute MIs is a different story altogether. But in stable coronary artery disease, the heart rate reduction does not improve outcomes. So independent association of heart rate with outcomes does not necessarily mean when we intervene, the condition of the patient or the morbidity condition of the patient improves or the morbidity comes down. So that is why we need an interventional study. So why should supportive care be provided to cancer patients? So if we are taking cancer subset, so why do we need? Because patients are usually diagnosed in advanced stages of cancer. So they need every help that they can get from the physicians. So the therapies which are initiated for cancer therapy may take some time to show their full-blown effect. So till that effect, whatever we have in our arsenal, we have to put it forward to protect the patient and to prolong life. So that is one of the theory. And the other one is because most of the cancer medications have cardiotoxic effects, thereby producing increasing heart rates and increasing the deleterious effects on heart. So that can be reduced. The association of heart rate with death by multi-organ dysfunction syndrome argues in favor of investigative treatment. So that's the same thing which I have been telling. There is an association which is found between high heart rate and high mortality in all these conditions which we have discussed, which are non-cardiac conditions technically. But reducing the heart rate is going to improve the lifespan or improve the quality of life is what we have to concentrate more on. So what's the future? Anchor et al. Have provided information in a paper called New Kid on the Block, namely cancer, which has high heart rate is also related to death. So this observation sets the stage for further investigation to show whether the heart rate is just a risk predictor or is a potential therapeutic target. That's what we are trying to do. So this hypothesis needs to be scrutinized in prospective trials, and prospective trials for each condition which we discussed is necessary to evaluate the outcomes, whether to give this benefit or to pass on this benefit to this subset of people so that they'll have a better chance of fighting these illnesses. Thank you.
If any questions, I'm ready to take.
Doctor,
Good evening, everyone. If there are any questions, you can.
There are no
share
questions on the
box.
chat box. You may discuss and then give the closing remarks.
So I think there are not much questions. Dr. Bipin, you would like to say something? And I think we are the last ones presenting.
Yes, madam. Yes. The thing is, as we all discussed, heart rate is a very important diagnostic, associative, and a therapeutic target also for all the illnesses. So we have been practicing it in cardiac illnesses, and newer agents have to be tested. As I have discussed, we have to go with arrhythmias. In arrhythmias, how it is going to benefit the patients. All this has to be looked at, and in other diseases as well. So yeah, that's my closing line. So you can discuss, madam. Please continue.
Yeah, so I think you have summed up everything nicely. So the thing is, we have to give importance to heart rate, like in your presentation, not only heart failure, the other cardiovascular diseases plus associated cancer. Probably the heart rate is not, if you see in a general practice, heart failure patients do go to general physicians and not just cardiologists, and this heart rate target is never achieved, if you see. So I went through all the talks, and it was a very comprehensive talk by everybody. The take-home message is to keep titrating, and till the patient tolerates, bring down the patient to at least 70 or below. It definitely has benefits, and use the various drugs available, beta blockers, ivabradine, if in atrial fibrillation, other drugs, and it definitely helps. So I think there are no questions. The talks were informative enough for people not to have doubts, or people are already post dinner and not in the mood to ask doubts. So we can conclude here, Dr. Bibit. Yeah. Thank you very much for the opportunity.
Thank you. Thank you all.
Yeah, thank you.
Thank you, doctor.